This video will cover the present recommendations for supportive care of COVID-19. Conditions continue to evolve, and as time permits, I plan to update the course videos. I will also be sharing updates quickly on Twitter at FS Southwick. Feel free to post questions on my Twitter feed. Given the time constraints, I don't have time to monitor other social network platforms. I have found Twitter to be the most efficient and reliable network for learning quickly about new developments in COVID-19 epidemiology and treatment. Use the hashtag #COVID19. Mention you are a student in the course, and I will be sure to follow you. I'm applying to create a community and hope we can create an official Coursera group in the near future. As discussed in the pathogenesis video, SARS-CoV-2 has a high affinity for the ACE2 receptor of the airway epithelial cell and quickly spreads to the bronchi and alveoli, where it causes inflammation and fluid accumulation, resulting in a ground glass infiltrates in the lungs on CT scan and a decreased ability to exchange oxygen from the alveoli into the arterioles. Patients with mild to moderate disease who don't require oxygen supplementation can usually be closely monitored at home to reduce the spread of infection in the hospital. However, the clinical signs and symptoms may worsen as the virus spreads to the lower respiratory tract. If you suspect you have contracted the virus, it is important for you to call your local COVID-19 hotline because each case will be different. Decisions on triage are best managed by a healthcare professional. Conditions that may be associated with worsening include older age, chronic health conditions, or an immunocompromised state. Significant shortness of breath is a warning sign and may warrant hospitalization. I want to emphasize that despite significant reductions in oxygen saturation below 90%, a significant number of hypoxic patients do not experience shortness of breath at rest. This is because early in the infection, there are no changes in lung compliance. Compliance being defined as the change in lung volume divided by pressure. Many infections reduce compliance of the lungs. That is, it takes higher pressure to expand the lungs, and this reduction in compliance creates a sense of shortness of breath. Also, COVID-19 lung infection is rarely accompanied by an elevated carbon dioxide or CO2. Elevation in CO2 in the blood is normally the primary signal associated with shortness of breath. Recognizing this reality, many health systems are now encouraging homebound COVID-19 patients to use electronic oxygen saturation finger monitors to follow their oxygen saturation several times per day. These digital monitors can be purchased for $30 to $40 online and run on AAA batteries. If an infected patient discovers that their O2 saturation is consistently below 92, they should contact their healthcare provider immediately. This guideline would not apply to patients with significant chronic lung disease. Most patients with chronic lung disease should be admitted to the hospital if they acquire SARS-CoV-2 because of their increased risk of complications and death. If you are in a high-risk group or are getting any worse, don't stay home. Seek medical attention. The earlier you receive treatment, the better your outcome. The primary goal of supportive care is to maintain oxygenation to provide time for the patient's immune system to kill the virus. Nasal oxygen at 4 liters per minute is commonly required to maintain an adequate arterial oxygen saturation above 92%. Recently, we have also been using high-flow nasal oxygen, 20 to 50 liters of flow per minute, with 40 to 80% oxygen levels to avoid intubation and ventilator support. High-flow oxygen provides positive end expiratory pressure, or PEEP, that can open collapsed alveoli or air sacs and improve oxygenation. We have not found that non-invasive positive pressure ventilation, called BiPAP, is helpful, and this approach causes what has been called barotrauma, excess trauma to the inflamed lungs, that can worsen lung function. Both high-flow oxygen and BiPAP cause the virus to be released into an aerosol, fine particles that can be inhaled and invade the lungs of those caring for the patient. If oxygenation can't be maintained with nasal O2, experts recommend going directly to intubation and mechanical respirator. This approach provides more reliable positive end expiratory pressure, PEEP, and ventilation. If full-blown acute respiratory distress syndrome, ARDS, develops, the patient should be placed in the ICU. Lung-protecting ventilation settings with low volume and high respiratory rate should be used, and patients should be periodically placed in a prone position. Prone positioning, lying the patient on their stomach, prevents the largest area of lung from being compressed and causing alveolar collapse. I have personally seen dramatic improvements in oxygenation when the patients are placed in a prone position. Another feared complication of SARS-CoV-2 infection is a marked rise in cytokines. Elevated levels of the cytokines IL-1, IL-6, and TNF can lead to septic shock accompanied by organ failure, as described in the case I presented in the clinical presentation video. These patients should be managed using a standard sepsis protocol. However, aggressive intravenous fluid administration should be avoided because these patients have fluid in their alveoli, and as a consequence of inflammation, and IV fluids can worsen hypoxia. I have shared the details of how SARS-CoV-2 causes a rise in cytokine in my previous discussion of fever, and will review these mechanisms in the video on treatment with corticosteroids, IL-6, and JAK1/2 inhibitors. In a study comparing Omicron to Delta variant infected patients hospitalized at UF Shands, submitted for publication, we have found Omicron-infected patients are less likely to require oxygen supplementation as compared to Delta-infected patients, 46% versus 68%. When it comes to high-flow nasal oxygen, this treatment was required half as often as for Delta patients. Illness severity tends to be lower in hospitalized Omicron patients. In our experience, they required MICU placement 1/3 as often as Delta patients. In addition to high-flow oxygen and BiPAP, other activities that can lead to dangerous aerosolization are intubation, bronchoscopy, obtaining nasopharyngeal samples, and nebulizer respiratory treatments. It is important that everyone caring for the patient don personal protective equipment. A tight-fitting N95 mask or controlled air purified respirator capper should be used during any of these procedures. And always wear eye protection, gowns, and gloves. In summary, mild to moderate disease not requiring oxygen supplementation can be managed at home with close follow-up and monitoring with a pulse oximeter whenever possible. The primary supportive therapy is oxygen supplementation with nasal O2, high-flow nasal oxygen, or mechanical ventilation. Omicron patients less often require nasal O2 or high-flow oxygen. In patients that develop acute respiratory distress syndrome, ARDS, low volume, rapid respiratory rates are recommended to reduce lung trauma, and prone positioning improves oxygenation. Elevated cytokine levels can lead to hypotension and a sepsis syndrome. Fluid should be cautiously administered so as not to exacerbate fluid accumulation in the alveoli. Omicron patients are less likely to develop severe or critical illness and are less likely to require MICU care. Providers must wear PPE, including an N95 mask, when aerosol production is anticipated. Thank you.